Question number 53. Grade 4 renal injury is depletion of collecting system. Involvement of collecting system is grade 4. Grade 1 is only contusion. Grade 2 is less than 1 centimeter. Grade 3 is greater than 1 centimeter without collecting system involvement. And grade 4 is deep collecting system involvement. And grade 5 is shattered kidney. Question number 54. Small soil enhancing lesion on CT at the lower pole of right kidney, 9 mm in size. For appropriate management, repeat CT in 3 to 6 months. Because small soil enhancing lesion on CT at the lower pole of right kidney, 9 mm in size, repeat CT in 3 to 6 months because small and less than 1 centimeter. Question 55. Urinary tract tuberculosis, which feature is atypical of urinary tuberculosis? Baric calcification. Because tuberculosis shows scar and reduced UB capacity, baric capacity. Baric calcification is atypical. Question 56. Primary infertility and oligomenorrhea, hirsutism, and BMI of 31. Which MRI finds or diagnosis? Multiple small peripheral round high T2 subsignal areas with hyperintense central stroma in both ovaries. They are seen in polycystic ovarian syndrome. Question 57. 12-month-old infant with aniridia and nephroblastoma. Series of bilateral enlarged kidneys with thick rind of homogeneous non-enhancing hyperdense tissues bilaterally heterogeneous enhancing mass with cystic change noted on one side and no William tumor. The aniridia nephroblastoma is featured of Beckman-Wiedemann syndrome, which is associated with Williams tumor. Question 58. Mountain biker suspected of sustaining a renal injury. A change to the right kidney on CT. Contrast has been during the paragraphic phase of the examination. What is the significance of this finding? Ureteric leak. Patient mountain biker and we are suspecting renal injury. Then there's dilation to the right kidney on CT and contrast enhancement during paragraphic phase. When the contrast enhancement during paragraphic phase of the examination, so there will be showing renal leak. So contrast leak, so renal leak. 59. Cyst as 2F. 2 require follow-up. According to Bosniak classification, which feature is seen in 2F, there will be seen multiple thin non-enhancing receptor 2F. Question number 60. KUB actually normal CDKB, so no calculus but a mildly dilated left renal system as far as the mid-ureter with periodic standing to this point. MR urograms of filling defect in the left mid-left ureter. Diagnosis of obstructive ureter calculus is made. Patient passes the calculus. Most likely, with clinical histories, a HIV positive patient on antiretroviral therapy because X-ray cannot see on X-ray therapy, and you also cannot see it on MR urogram. It's a spelling defect. So HIV positive patient on antiretroviral therapy. Then 61. 43-year-old woman with a history of breast carcinoma undergoes CT of the abdomen for abdominal pain and MRI. This remains enlarged uterus and she proceeds to MRI. The normal T2W zone around her uterus is preserved. The endometrial stripe is of high T2 signal and measures 14 mm in diameter, and myometrium is thickened. Data is light enhancement of high signal T2W post endometrial area demonstrated on the T1W post contrast administration. There is no evidence of myometrial invasion. Where the diagnosis is most consistent with these findings? Tamoxifen therapy. No other makes sense, and this enlarged endometrium is seen in tamoxifen therapy because let's go 61. The normal endometrial stripe is of high T2W signal and measures 3 to 6 mm in diameter in the follicular phase and 5 to 30 mm in secondary phase. Lesion of endometrium in this case is consistent with endometrial hyperplasia with the addition of myometrial enlargement. Enlarged uterus is frequently encountered in the presence of endogenous or exogenous hormonal abnormality. In this case, uterus is usually a normal tonal anatomy. Although signal intensity in endometrium might be abnormally increased, however, with tamoxifen, the uterus can display a marked zonal anatomy distortion. It is a estrogen agonist. Which tamoxifen is estrogen agonist, and it can show my increase. Here, endometrial stripe is 14 mm, but is increased in size slightly, and myometrium is also thickened. So this irregularity and uterine anatomy can be seen in tamoxifen therapy with estrogen agonist. Question number 42. 3 cm renal cell carcinoma patient undergoes square ablation, which suggests incomplete treatment or recurrence. The ablation zone unchanged in size over time. Shows incomplete treatment or recurrence of renal cell carcinoma after square ablation. Question 63. Renal rotator action ureterogram shows contrast exacerbation below the urogenital diaphragm only. What type of uterine injury is anterior injury? If contrast exacerbation is only below the urogenital diaphragm, then it is anterior ureteral injury. Question 64. So 4 cm left renal mass, which will be most consistent, was helpful when determining if there is transient cell carcinoma in renal cortex rather than renal cell carcinoma in the corrective system, maintenance or uniform shape. In transgenital carcinoma, the renal shape is maintained, it is not distorted. So, in renal cell carcinoma, there will be distortion of the renal shape. Question 65. A 38-year-old patient referred for an urgent IVU and was shown by the GP who has picked up mild renal impairment on renal blood test. Ultrasound shows two normal-sized kidneys with no evidence of vertical loss. The IVU shows normally enhancing renal outline, but the pericardial system is abnormal. Some calluses show non-specific clubbed or blunted appearance. So clubbed calluses are seen in NSAIDs, chronic NSAIDs or clubbed or blunted appearance, and then their acute the thin tract or nerve stemming from their calluses. Other calluses, in a number of calluses, there is a filling defect noted with in or rounded blunted callus. From these patients, you are able to make a diagnosis. The patient has a classical history of this condition. From the history of which is the most typical history, chronic and shared analgesic overuse. Shows renal tumor necrosis, acute tubular necrosis, clubbed calluses. Question 66. A 37-year-old woman presents with a watery vaginal discharge. Renal papillary necrosis shows calluses and seen and shared overuse. 66. A 37-year-old woman presents with watery vaginal discharge and attempts for MRI of pelvis. She becomes quite claustrophobic at the end of the scan, and you are called to assess her as she has been hyperventilating. And the radiologists have become concerned. As you assure her, you notice some perioral pigmentation. MRI reveals a multicystic lesion, high T2 and low T1 signal in the uterine cervix, with a solid low signal T1 and T2 common in the deep cervical trauma. You note from the picture artery and PACS system that a barium anemia previously reveals severe colonic polyps. What is likely cause for MRI finding? Minimal deviation adenocarcinoma of the cervix. Because she has familial adenomatous polyposis, that is prejagged syndrome, because all pigmentation and is associated with adenocarcinoma of the cervix. Now let's see the explanation. So the patient is seen with patient with prejagged syndrome and with microcutaneous pigmentation, multiple hematomas, polyps of the GI tract, and mucinous tumors ovary. MRI appearances are also like this. MRI shows multicystic lesion, vertical vaginal discharge, and a multicystic lesion, high on T2 and low on T1 in the uterine cervix with a solid signal, common in a deep cervical trauma. This is all related with Creutzfeldt syndrome. No other makes sense. If the patient has Creutzfeldt syndrome with a lesion in the cervix, so diagnosis is minimally deviated when adenocarcinoma of the cervix. Question 67. Patient had a gynecological cancer that was treated. HRC was unilateral thickened into lobar septa, polylymphatic nodules, and ipsilateral hyperlymphadenopathy. So this is lymphatic carcinomatosis due to cervical carcinoma. Cervical carcinoma was treated by radiation therapy and patient developed lymphatic carcinomatosis. Question 68. HCG shows multiple small outpouring from the uterine cavity. Diagnosis: adenomyosis. Self-injected isthmian nodosa is multiple outpouching from the fallopian tube, but this is adenomyosis from the uterine tube cavity. 69. Divergent uterine horn with deep midline funnel cleft, two separate uterine cavity, two separate cervices, and a unilateral hemivaginal septum causing hematometrocolpus. From uterine anomaly is uterine diadelphys. It has two uterine cavity, two cervix, and associated with vaginal septum in 75% cases. The diagnosis: uterine diadelphys. Question number 70. Suspected bladder injury. CT shows more orthos appearance. What is the significance? More orthos appearance on bladder injury is extraperitoneal rupture. Question number 71. M6TC BP, which is such as a diagnosis of parathyroid adenoma, such as MEPSCAP. Focus on increased radionuclide activity within the lower pole of the right lobe of the thyroid on thyroid imaging. Increased radionuclide activity in the lower pole of the right lobe of thyroid on thyroid imaging only shows parathyroid adenoma. Others don't make any sense. Only on tumor imaging, not on initial imaging. Also, it increased radionuclide activity, not decreased radionuclide activity. So only on thyroid imaging again, and then focus on increased these. It's on delayed imaging only, correct? So last Answer. When a 50-year-old man is discovered to have a cystic abnormality of the lower ball of the left kidney during an sonogram scan performed for right upper quadrant pain. We think this might be a complex cystic lesion and therefore require a CT scan of the urinary tract. This shows a conglomeration of variable sized cysts at the lower pole of the left kidney, but no capsule or mural irregularity of the cyst. Most likely diagnosed localized cystic renal disease. Conglomeration of variable sized cysts in the lower pole of the left kidney, but no capsule or no irregularity, so this is localized cystic renal disease. He is discovered through incidental finding. 1973, Payne had a renal transplant. Orson showed mild renal pelvic dilatation. Pulsatility index was 2 and the resistive index was 0.9. The patient was uric. On day 4, Payne became anuric after renal transplant patient. So you notice that there is reversible dialytic flow evidence on pregnant waveform, but in other areas there is no flow evidence in the interlocal arteries. Resistance index is now 0.95. And then you see tubular structure of intermediate extension renal hilum. Now these are reversal dialytic flow, and then you see tubular structure in amyloid, so this is renal vein thrombosis. And what most appropriate next investigation step is refer for intermediate venous intervention, which diagnoses renal vein thrombosis, tubular thrombosed renal vein. The tubular structure in the renal hilum is thrombosed renal vein. Question 74. We are asked to assess the renal transplant kidney in the early post-operative period for any abnormality and to serve as a baseline study. Which of the following findings on coronary Doppler ultrasound with regard to a PI, RI, and P mode ultrasound imaging with regard to renal morphology would be considered within normal limits? RI is less than 0.8, PI less than 1.5, RI less than 0.7, and prominence of hair parameters is normal limits. Question number 75. 28-year-old para 0 plus 0 female patient is referred from gynecology team for an MRI with the pelvis after presenting with pain in the INF. On TBUS, they have identified enlargement of the right ovary and have raised the possibility of a mass on MRI or 2 cm ovary lesion demonstrated within the right ovary. It is of high signal T1 and T1 fat saturated sequences and low signal T2, so this is all endometrioma sign. It contains fats, it contains blood and other contents, so there is no evidence of a mural nodule or ascites, and uterus is not enlarged, likely diagnosed endometriotic cyst.